Alrighty. Welcome, everybody. We're gonna talk about prescription drug use and abuse. How many of you don't have to share who, but know somebody or have taken care of somebody who is addicted to prescription drugs? You guys know people in your life? Yep. And was there a certain incident that got them addicted?
Cancer. Oh,
Cancer? Okay. Sometimes car accidents can happen and people get prescribed.
back surgery. I've seen people, lots of people die from back surgery and.
Yep. So very common. You hear about it on the news all the time. We're in an opioid crisis. Used to be, I mean, it changes with each decade what the latest and greatest of our drug epidemic is. Right now, fentanyl is really big.
Yeah.
So very dangerous drugs. So we're gonna discuss some medications that are the most used in that we see the most abuse in. Some conditions that are associated with drug seeking behaviors that we might see in some of our clients or family members. So it's kind of education for all. And then some interventions and responsibilities that we can implement from a professional level. And then we're going to define drug abuse, drug tolerance, drug dependence, and drug addiction. So, all right. So first part, too much of a good thing can be bad. So main thing that we see with opiates or drug abuse, what do you think they're trying to cure?
Number one reason.
Number one reason is pain.
Right.
Yep, very good. All right, so that's what most people go to the doctor for is, some people will have a cough for months, never go see a doctor. But if they're in pain, chronic pain that's not getting better, they're going to seek a physician's help. The problem that they're finding in the medical field is that doctors are between a rock and a hard place of prescribing pain medication because there is such a problem with addiction. So we're finding more and more of our clients are angry because they're not getting the pain medication that is helping them, and they might not even have an addiction. It might be something that has to keep their pain at bay so that they're just functioning. But how do you define someone else's pain? Right. So you have your objective data and you have your subjective data, and pain is subjective. It's whatever your client tells you. So you might see somebody, little old lady sitting there and she's just talking, going about her day, but she might be in a level pain 8 out of 10. Her pain tolerance is at that point, so she is still functioning, but it doesn't mean that they're not in pain. So we as caregivers really need to be good judge. We need to not be judgmental to these clients, but we need to be good judges of when to seek outside help if we see that addiction is becoming a problem. Okay. So pain is the body's indicator that something is not right. So I see some patients sometimes who will tell me, this wound is so painful. Well, that's actually a good thing. You want to have your pain receptors in check. Once you don't, things get worse. So you'll see a lot with your diabetic patients. They might have the nastiest wound on earth and you're taking care of it. They go, I can't feel a thing. Well, it's not good. Right. Pain is actually a good thing. We want it to be there, but we want to keep it at bay so that it's not taking over their lives. A lot of times when you see patients or clients who are in chronic pain, it starts becoming not just physical, but mental. So you see a lot of these patients who are in chronic pain start to develop some depression. All right. So what we find in our profession mostly is back pain from a lot of transferring and improper body mechanics. It's very important to remember to ask for help when you need it. Ask for like the Hoyer lift behind you guys. If you feel that your client is not strong enough and too big, you really do have to protect yourself as well, because we see a lot of people who work in healthcare become victims of painkiller addiction as well. Which is not good because then it affects our jobs. To prescribe or to not prescribe, that is the question. So, like I said, more and more, we're hearing more about the opiate crisis, but it doesn't necessarily mean that doctors should stop prescribing opiates. You might even find that some of our clients, that's why they seek caregiving services, nursing services with us, they're post-op and they're afraid to take pain medication because they might think that they're going to get addicted to it. I find myself when I'm giving, education to them saying you should take the pain medication. It is important to dive a little bit deeper and say, do you have a past history of drug addiction? Because for some of those clients, it might be better for them to go a more holistic approach than to dive into that bottle of Norco. It also is important to know that it is okay for them to take pain medication if they can tolerate it. Right. Because when you are in pain, you're not going to heal as fast. You're going to be more immobile after surgery if you're in chronic pain, or if the pain's too bad to do your physical therapy, and then things start taking a downturn. We want to make sure that they are adhering to the directions for use. So we do medication reminders. All of the clients that we see should have a list of medications on their profile. Usually pain medication, like an opiate, is every 4 to 6 hours. We want to make sure that we're not giving it to them earlier than that. So we kind of need to be the sound mind for them because they're not thinking clearly. They're in pain. Say, you know what, Mrs. Jones, you can't get your pain medication for a couple more hours. Let's try to do some deep breathing. Let's try to do, if it's recommended, some ice therapy, heat therapy, whatever it is, that injury that's causing it. All right. So the next little section above the box that says most commonly abused prescriptions. This is kind of just a generalized thing that people see in the hospital for patients who are drug seeking. This individual had went into the emergency room requesting pain medication. Sometimes these clients go into a emergency room specifically on the weekend or at very busy hours of the hospital where they know that the doctor is not going to have enough time to check that patient's medical records and see if they have another doctor who's prescribing these medications somewhere else.
They're trying to just cheat the system.
Yep. And it's not everybody, and it's wrong of us to assume that everybody's that way. But this is just commonly seen in our hospitals. You're gonna see some of these people have multiple addiction issues, such as alcoholism as well. Because alcohol is very short-term pain relief, and pills are longer. Some of these patients are going to have, I'm kind of like giving you guys a general, so I don't read this word for word because that gets boring. A lot of these people have really irregular labs, so their liver functions are way off because pills do affect your liver the most. They also, alcohol as well affects your liver. And a lot of these clients get very angry when they don't get their way. So if you do have a doctor who tells you, you know what, I think you should see your primary care physician who knows you best. If they are drug seeking, they will most likely be very angry with that physician. Okay. So our most commonly abused prescription drugs. We have our stimulants. I'm sure you guys have all heard of Adderall, Ritalin. We're putting kids on this much earlier and earlier in life for ADHD. But it does have a very addictive characteristic on the brain. So it stimulates the dopamine in the brain, can help with anxiety, it can help with ADHD, does give you a sense of euphoria, but it also increases the heart rate. So you'll see if people are on this younger and younger, they are developing heart conditions earlier in life than they normally would, even if they have like a comorbidity going on. You'll see more weight loss in these people. So the stimulants actually attack your appetite as well, so they don't want to eat as much. And then methods of abuse for stimulants is that they can be snorted, inhaled, and they are water soluble, so people go as far as watering them down and then injecting them into their veins, which is very, very dangerous. The next are going to be our opioids. So, opioids are mostly prescribed after something post-op. That's when you see it the most. We have our Oxycontin, our Percocet, Norcos, things like that. These do affect your GI tract. So a lot of your clients who have are on, opioids long term, they might have a lot of GI issues. They might need more of the Miralax to help them go to the bathroom regularly. This is the same as the stimulants, as a lot of them are water soluble, so they can be taken in a not good way of snorting and crushed and injected as well. And then they can also lead to opiate overdose. So this is where you're gonna see like your Narcan come in if somebody were to overdose on these. Next are gonna be your barbiturates, your benzodiazepines, and your sleep medications. So these all have very similar characteristics. Basically, they are slowing down the brain. Your barbiturates are going to be treating like more of the epilepsy and sleep disorders. A lot of people do pair barbiturates with alcohol to enhance the effect of them, which is very, very dangerous. That's like what Marilyn Monroe died of. She was taking barbiturates with champagne and her respiratory system shut down. So, you're also gonna see it, they'll take like a Benadryl too, because the barbiturate, they've got a big tolerance to it, and they'll take a Benadryl to almost decrease the high of the barbiturate. Heart rate and respiratory rate are slowed enough to cause a fatality. So most of these people who have an addiction, we're finding are dying in their sleep. The benzodiazepines, these are gonna be like your Xanax, your Valium, and it's not that these drugs aren't good for treating certain disorders. We just want to make sure that they are not abused. Some of our clients might have just chronic anxiety, or they might have, had a horrible life. They might have lost their kids, their husband, had something very traumatic go on in their lives. People who are affected by the fires, of course, they're going to have anxiety and bad dreams. We just want to make sure, that they don't pass that point of abuse. These all kind of affect the same part of your brain. It will be your GABA neurotransmitter. These can cause drowsiness, so you also want to remind your clients, if they are still currently driving, please do not take a Xanax and, drive. It's very dangerous because your reaction time is quite slower. And then withdrawals, we see more in the Xanax and Valium than we do in the barbiturates. The withdrawals cause, down the line, seizures. Our sleep medications, these are usually very acute. So I've seen the commercials before for like Lunesta, where the green butterflies flying around. Have you guys seen that before?
Mm.
Okay. Ambien. These are to treat people with insomnia. Like I said, if you have like a traumatic event go on and you just need a little bit of sleep, obviously that's important and these are okay to take for a short period of time, but you can become very dependent on sleep medication. When you are taking sleep medication, you are not getting an actual rest, even though it feels like you're in a coma. I've been guilty of it too, where I've taken ZQuil because I'm like, I just need to get 8 hours.
Mm.
But if you have like a watch or a ring or whatever, you can kind of see your REM sleep is not there, even though you're in a deep sleep, you're not having that healthy quality sleep that you should. For these patients, it is also very important to remember that they shouldn't be drinking alcohol with them because that can cause more hallucinations. There have been cases of people doing like violent crimes on these sleep medications, and they're just not in their right mind. It's almost like a sleepwalking.
Mm.
But again, just look for the signs, guys. They're usually pretty simple to see. Your anabolic steroids. So this is most commonly used in our males, and it's to build your muscle mass, build your increase your bone mass as well. We see this causing some impotence in males, smaller testes, infertility, things like that. It is mostly abused by teens and athletes. So it can result in some short-term, but also some long-term health issues down the line. Stunted growth, aggression, because it's increasing your testosterone. And then also some liver cysts and cancers. And then atherosclerosis. So we're going to see the arteries start to harden because they are just being overworked with the steroids. The steroids are not necessarily healthy when you're forcing them into the body as opposed to just naturally being produced like they should. Muscle relaxers, a lot of times these are going to be prescribed after surgery as well. These are going to be great for your patients who have MS, cerebral palsy, fibromyalgia. They can really help somebody with chronic pain just operate without having the sense of a high, like an opiate would give you. Some people do feel like very euphoric feeling from muscle relaxers, but it's more of a calm feeling as opposed to being like a stimulant. And then, so these really just target the musculoskeletal system and act on the muscle fibers just so people can relax. So some of our quadriplegics as well, they might, even though they can't feel things, they might get muscle spasms and it really irritates their sleep. So these are really great for them. With abuse, you're going to see some upset stomach. Again, it's going after your muscles. So, and again, don't mix any of these things with alcohol. Fentanyl, so the big ol' bad drug. This really should be used in surgery. It's pretty much the only place it should be used. Aside from fentanyl patches, which can be great for people with back pain, you should not be touching fentanyl patches. They're very dangerous. They should be handled by a medical professional who knows how to triple glove. Because if it gets on you, you could have really bad reaction.
And my mom had it when she had the dementia.
Mm-hmm.
She was in the bed and we were her caregiver for 5
Mhm.
years.
Mm-hmm.
There were times that tried to peel it, then I had to put the gloves on because
Mhm.
then you start to feel a little strange.
Yeah. Mm-hmm.
And right away had to wash my hands,
Yeah.
but yeah, we'd change them like, what is it, every 3 to 4 days. Or
Yeah,
whatever,
but they're
so.
very potent.
Yes,
So
Yes.
it's scary. And
Yes, it is.
especially if you're very sensitive, I mean, people have collapsed.
Yeah,
just touching them for a
one time-
second.
One time, because I was working up city, I don't want to get too into the names of the facility or rehab,
Yeah.
whatever. one of the guys, like, he had like a bagel in his mouth and he OD'd on something. I don't know if it was fentanyl, but I'm kind of
Mhm.
assuming it was.
Mm-hmm.
And he had like the bagel in his mouth and he just kind of fell back and passed out.
Mm-hmm.
And like he was ODing and stuff. So
Mm.
like we were in there trying to, stabilize him or whatever.
Mhm.
And I remember I picked up the bagel that was in his mouth and I just kind of sniffed it
Mhm.
and I was like, whoa, and then I put it like on a plate and I kind of put it in the trash. That wasn't sure if the cops were going to see it or whatever. And then he kind of picked it up and did the same thing out of the trash. Like he's where's I already have food in his mouth or something. I threw it away, it's in the trash. And he
Yeah.
did the same thing and he almost passed out
Oh
too.
my gosh. Wow. That's scary. Very
Mm.
scary.
Like he actually kind of took a knee. I mean, I stumbled back and he like took a knee and kind of fell over and then like the paramedics kind of like took him out. And,
Yeah. It's really scary.
Have you ever heard people afterwards sucking on their fentanyl patches? Yeah.
Oh, yeah.
In
I
Arkansas,
saw
yeah,
that.
there was a girl and she would constantly, and they found her dead in her apartment a week later,
Mm-hmm.
but she would take them off.
Mm-hmm.
And my sister-in-law said she would just literally suck on those fentanyl patches to get
Awful.
every
Yep.
drop out of there.
Awful.
Yes.
It is really sad. I've seen the videos. We had a lot of it on our
Mhm.
streets. And yeah, really dangerous. Okay, so this is really a well abused drug. Abusers often mix this with heroin, cocaine, or other illicit drugs to increase their high. I also knew somebody who she would take Benadryl with her fentanyl to make it increase in her. I don't know how she stayed awake ever. But yeah, no, super scary. So this can cause confusion, sedation, unconsciousness, coma, obviously decreasing your respiratory system quite a bit. So we've seen a lot of deaths from our fentanyl problem. Okay, so the role of healthcare providers, kind of discussed this, but it is a major dilemma of how much a doctor is going to prescribe. So I do see a lot of my patients tell me, oh, I had surgery, I'm in so much pain, the doctor only gave me 10 pills. What's that about?
Right.
You know, people ruined it for
Right.
Mhm.
the
Abuse
good.
it.
The good, yeah, because there are going to be your patients who truly need it.
Mm.
A lot of times we recommend that they go see a pain specialist at that point, not a primary care, because they do have a little bit more, I don't want to say pull to get you your meds, but they're going to do a more comprehensive tests on these patients and then maybe give them more options that aren't necessarily pharmaceutical. So they can do things like nerve blocks, epidurals, just different things that might help them more long term than popping a pill every day. So we have to really just be careful of recognizing the drug seeking behaviors and then making a decision from them. So narcotics other than opiates, narcotics are widely prescribed in the United States. It's really easy to give somebody a pill, almost to get them to go away. I think some doctors are bullied into giving people pain medication just to get a patient to shut up. You know, they keep seeing them in their office every week and they're like, fine, what do you want? Just get out of here.
Mm.
But that's not necessarily good. It causes more issues down the line. And some people are not necessarily taking into effect mental illness on top of this. So you might have some patients who are also taking some psychotic drugs on top of the opiates, and then we're seeing it kind of contribute more to our crime. There's going to be some mood altering substances, and those are going to be because of the drug having rapid onset of action, high potency, the brief duration of action, high purity, water solubility, like I said, if something has water solubility, people have the option of watering it down and then shooting it up. So this is what, this is mostly highly addictive drugs. And then high volatility as well. So your high volatility are the ones that you're gonna see, they have the ability to smoke. You're gonna see, and everybody's got a different opinion on it. I'm not here to push it, but you will see that people will progress from prescription drugs to higher illicit drugs. Okay, some people will say weed is the gateway drug. I'm not here to say that. I'm just saying that as you progress, people change. So some people will go from methamphetamine to cocaine to heroin to whatever. They can switch drugs because something might not be giving them the high that they need. Again, these people are trying to numb their pain in some way. So, some people numb their pain with alcohol, some numb their pain with, anything. All right. So your benzodiazepines are going to enhance euphoria, alleviate withdrawal, temper cocaine highs. So you'll see some people be on the uppers and downers because not everybody can stay awake for 3 days straight. Eventually they're gonna have to sleep. Augment the effects of alcohol. So some people will almost get higher up with alcohol with benzodiazepines. You would think it would tank them, but it might actually make them more awake and they won't feel the effects of alcohol like they would. And then ease withdrawal states. So some people who are kind of coming off of alcohol, they might get the shakes. They might take a benzodiazepine to kind of chill them out and stop the shakes from happening. So substance abuse is defined as continuous compulsive use of a psychoactive substance despite any physical, psychological, or social harm to the user. So sometimes we will see it will cause adverse health effects in people. It will disrupt their safety. They're not going to be as, they might engage in some risky activity like, sex with strangers. They might drink and drive or take a drug and drive and not realize, I've heard some people say, I'm the best drunk driver ever. You're not. That's the alcohol talking, So yeah, you will see people who have substance abuse begin to engage in some more risky behavior. And it might just be started by something that is very simple. So they just have back pain. All of a sudden, I'm taking a pain medication. Oh, now I'm going to take a pain medication with alcohol. Oh, now it's not working anymore. I'm going to take 2 pills, then 3 pills. And, you start getting into this vicious cycle and tolerance. People will double up on their medications, but think, oh, it's okay, without consulting with a doctor. So they're not realizing that that double dose is actually causing more harm to their liver. Or they're not taking into account that maybe you have a friend who takes 2, but he's 300 pounds and you're 90 pounds. That's a big issue. Sometimes people will take their spouse's medication in addition to their own. That's also very dangerous. When your doctor prescribes you something, they are looking at your whole medical history and, any heart conditions or asthma or whatever. It's not good just because the drug is in the home for you to take it. It wasn't prescribed to you. All right. And then individuals who abuse drugs will eventually meet the criteria of a substance dependence. So dependence is exactly what it sounds like. It means that they cannot function either psychologically, behaviorally, cognitively without the use of that drug. So the DSM defines substance dependence as meeting the criteria with at least 3 of the following things I'm going to mention in a 12-month period. So tolerance, withdrawal, substance taking in larger amounts or for longer periods than intended, persistent desire or unsuccessful efforts to cut down or control a substance use. So they're just not able to make it through the day without having at least one of those pills or one of those drinks or whatever it may be. A significant amount of time spent in activities to obtain that substance. So they're hanging with the wrong crowd, people who also engage in this activity. They might be giving up on their social life. They might be skipping work because they're just way too high to make it through the day at work. Or just recreational activities. So they might have, been involved in a church or might have been involved in coaching a soccer team, and they're just giving up those things for the sake of that drug. And then continued substance use despite the knowledge of having persistent or recurrent physical or psychological problems. So they're throwing up every day, but that's okay because at least I'm,
Don't have a system.
yes, exactly. They think they're functioning at that point, or psychological problems I do see with abuse. They totally forget having a conversation with you the other day. And they have the same exact conversation with you 2 days later. You're like, don't you remember me coming over? So it's sad though. It really is ultimately sad. All right. So they can have a dependence on any of the drugs that we have mentioned at this point. You will see some of them if they are going through withdrawals, the anger increases. They might get, shaking hands, dry mouth. They might have kind of itchiness. We see that as well because they're just very uncomfortable and or the pain is increasing so much and they are all of a sudden in complete pain at that point. A lot of them will start sweating too. It is important for them to taper off as opposed to just stop cold turkey. All right. And then tolerance is just when they have to keep increasing their dose in order to reach that pain level. Yeah, the tolerance of it increases, which is really dangerous. We do see this happen. We don't usually see this happen in patients with cancer pain. That's kind of the only exception because the pain for them obviously is increasing too. So.
Really
Yeah.
quick, somebody excuse myself because I have to go.
No
Thank you so much.
No problem. I think, did you get your little thing?
Not this one, that's okay.
Are you sure? Okay, I can email it to you. All right. And then. See what with that. All right, so we're gonna skip down to risks associated with drug addiction. I think page 9 here. So they have found that risks associated are gonna be genetic. We do see that a lot even with our alcoholism and with drug addiction. It's not always that way. If mom and dad are addicted, it doesn't mean you're doomed and that you're gonna develop a drug addiction. It just means it is more common. Gender, ethnicity, and mental disorders also play a role. So we do see it a lot in our military as well, sadly. Stress plays a major role in people's addiction issues because they're trying to numb something. And then environment, family, friends, who you spend your time with will affect you. That plays into peer pressure as well. Physical, sexual abuse, like I said, those traumatic events, you're just trying to numb your mental pain. Development and then genetic and environmental issues that affect your developmental stages. So sometimes people are just peer pressured into it and they don't have the mental capacity to say no. So we do see that a lot. See it also with abusive relationships is one partner will say, come on, try this. Person might have never had a drug issue in the past, but they got pressured by a partner. And then medical histories, we're gonna see that in, the signs and symptoms of substance abuse and addiction. So medical histories are going to be, what we look at when we basically see if somebody has, some comorbidities going on. So they might have some, I'm sorry, guys. They might have some anxiety issues in the past that haven't been properly treated, so they've been put on medications to treat that for a long term. This might show signs of personality changes, poor performance at work or school, accidents, or carelessness. So these are just things that might be part of the substance abuse. Underlying illnesses that cause pain or anxiety must be discovered prior to prescribing addictive medications. So when you are regarding the history of psychiatric disorder, treatment, and current status, as well as family history, diagnosis should be supported by history and physical findings. So if there are signs of narcotic abuse, there's going to be signs like complaints of constipation, the itching skin, nausea, vomiting, vital signs that are abnormal. The patient might appear sedated or euphoric. Respirations can be very shallow. Eyes are bloodshot. Pupils can be small. Speech might be slurred, so they look impaired. Okay. And then also for the ones who are doing intravenous drugs, we want to make sure we're looking for the needle marks and skin lesions. And then complications of abuse include skin infections, usually with our clients who are very highly addicted to something. They're going to be less inclined to perform proper hygiene of themselves. So we might see more lesions or urinary tract infections, just anything that can, just wounds on the body. Intestinal slowdown, seizures, infectious arthritis, and loss of the menstrual cycle. So sometimes that is contributed to their lack of proper diet that affects the menstrual system. And then, like I said, withdrawal exhibit signs and symptoms are going to be increased salivation, nasal stuffiness, muscle aches, vomiting, abdominal cramping, sweating, confusion. All right, and I went over the emergency room visits. I said that most of the time when people are going to be going to the emergency room, it's going to be on weekends or very busy times, when the doctors are going to be very busy and can't properly look up your medical history, or it's just not available. Some people may say, hey, I'm in from out of town. Well, how are you going to get that information from a hospital in, Utah at 3 o'clock in the morning? You're just not. All right. Identifying potential abusers. This is going to probably be some continued return visits with different kinds of ailments. So my back hurts, my foot hurts. I saw it a lot when I was working with a pain specialist. They'd come in with a new injury every week. And that's a big red flag. It's like, how do you get hurt so often? Most of the time they're doing it to themselves so that they can either
Come in and get that.
yeah, we have a new reason to give you some meds. Doctor shopping is more common than we think. People will either find a doctor who has a sweet spot for administering drugs and prescribing drugs, and then they tell their friends about it too. Dr. Jones will, Dr. Jones will always give you pain medication. That's really dangerous. And some people will use it to get medication from different doctors, so the doctors shop, and those doctors might not know about each other. Others will use the medication and then sell it on the streets for a higher price to somebody who wouldn't be eligible for that med. Usually these are kind of some scenarios that you might see is they have a list of symptoms. A lot of times drug seekers are really pretty sneaky and smart. So they'll tell you most of the time what doesn't work for them. So they'll say, oh no, Norco doesn't work for me, only fentanyl. They might have allergies to some medications, or they know the name of certain drugs really clearly that they shouldn't know unless they had a medical background in it. They might accidentally offer some contraindications for those drugs. So they might say, oh yeah, I do have liver disease or I have asthma. They'll get upset when they accidentally slip on those. And then they might mention that only a certain controlled substance works for them. They also may illegally buy prescription narcotics from the street and supplement them with their legal prescriptions so that they don't run out as quickly, and so the doctor doesn't catch on that they're running out fast. And I've mentioned this, but they might become belligerent and accuse the doctor of incompetency when they don't get their way. They might also threaten to sue that doctor. Yeah. All right. And then potential signs of individuals seeking drugs, which is kind of the same thing. Doctor shopping, recurrent pain without obvious cause, calls to the office with complaints of unrelieved pain, calls on weekends, visits to ER to see through the next visit, and requests unnecessary treatment in order to obtain pain prescriptions. So yes, I did have a patient before when I was at the pain specialist, and this guy would say he fell all the time to keep getting epidurals. And I went, you have to go undergo anesthesia, all these things. He just loved epidurals. He would come in like once every couple months, and I went, you're really gonna cause more damage to your body because it's breaking down your bones. But all for pain relief, right?
And couldn't that also travel somewhere else?
Mhm. Yeah. Definitely. Yep. So the legal issues is really boring in this section. I'm just touching base on it. The main part you need to know about this is if the patient admits to drug abuse, he should be offered drug counseling and referrals. Okay. So the goal for everybody is pain relief. You don't want, doctors don't want to see you in pain. They want to do the right thing, but also it can get them in trouble with their licenses. So don't expect, to call the patient and say, the patient's doctor and say, why aren't you giving them pain medication? They might just be trying to protect themselves as well as the client from developing abusive behaviors. Okay. And then safe practice is really just no one should be prescribed any kind of narcotic without first examining the patient's medical record. So we want to do good, not harm. We do not want that patient to develop liver problems, respiratory issues. We don't want to cause more problems down the line besides the pain. Other alternatives to oral medications should be explored, like acupuncture, relaxation technique, psychotherapy. Physical therapy is a big one. So maybe people just have contractures and they need to get moving and stretched out. Hypnosis, yoga, not you, the yoga. It's yoga issues today. And yeah, and then complementary and alternative therapies can definitely be used. It is found to relieve about 50% of pain cases. So it's worth exploring other options besides taking opiates. And then as far as maintaining a legal profile, this is really just having clear instructions on the proper dosages and side effects of the medication, patient education requiring the potential risk for physical dependency and possibility of withdrawal effects is important. So, you guys might see too, if someone's taking a sleeping medication on the bottom, like an over-the-counter one, it will say non-habit forming. It doesn't mean that they're not going to be taking that sleep medication at night. But as opposed to like the barbiturates and the sleep medications that are prescribed, they don't affect the brain quite as much to be considered addictive drugs. So like your Z-Quils or something like that aren't necessarily going to be the next epidemic.
Right.
Right? Okay, and then your summary is that all prescription drugs have the opportunity to be abused. There's a time and a place for them, and really we want people to be using them acutely unless they have a chronic disease like cancer or something where it's not gonna get better, but the pain medication is just kind of keeping them going. There's a quiz. Yep, there's a little quiz. We can go over it. Yeah, we can do it together.
Should we read them together or
We can, yeah.
maybe?
You wanna do it together?
Yeah.
Everyone's tired. Okay,
Mother.
I know, it really is. Okay. All right. For number one, which of these medications is a stimulant? For number two, which one is an opioid? This one was hard. I actually had to look back. Yes, good job. Good job, Cheryl. Next one, which one's a barbiturate? Valium.
Really? Cause I was looking at that thing when I was.
Okay. That's right.
Two is C.
No, two, three.
How much is
B. Mm-hmm.
this?
Number four, what do you think?
I thought about pictures, but
And it really can be all of them.
Yeah.
It kind of just depends.
All
But
the.
I know it really can be all of them. So we circle all of them. The answer is B, actually. I guess so. Yeah. And then number five. Number five is D. Number six.
Opioids.
Oh my God.
It's going to be your D. Your opioids are going to cause the major for constipation. Yeah. And then number seven.
Wow, good. This is only
No, it's number C. For seven. Number C. Letter C. Sorry, guys. Sorry. It's a long day. Okay. Number eight. D. Yep. For nine is D. Yep. And then 11.
Which of the following behaviors is not a criteria for recognizing addiction?
It's C. Yeah, it's like a backward question because we're not. Keywords. Yes, not. All right, what'd you guys get for 12? C, yep, good job.
Which is not a sign and symptom of CNS hyperactivity?
That's all.
You guys do